So when we look at this, you will often see, particularly from some of the big donors and funders out there talking about HIV, it seems kind of like key populations are an afterthought, a kind of an aside, an issue of special concern that we all have to deal with. That's not right. What key populations are, as you can see from this slide from WHO, is, for example, 70% of new infections in the United States. This is the epidemic, right? There isn't some other epidemic. So what do we mean when we talk about key populations? So my group has defined this as really just two features. So one is a disproportionate burden of HIV infection and a lack of access to essential HIV services. If you meet those two criteria, we would put you in our category of a key population. So who are we talking about? Of course, gay, bisexual, and other men who have sex with men, sex workers of all genders, people who inject drugs, transgender women who have sex with men, and women and girls in East and Southern Africa in that hyper-epidemic zone, and of course adolescents from all of these communities. So adolescent key populations, probably the most challenging part of where the HIV epidemic is going, and unfortunately, as many of you know, where the new infections really are. So we looked at Kate Shannon from University of British Columbia, did a great piece in this Lancet series with a modeling group, looking at all the different kinds of interventions and packages, including treatment as prevention, including PrEP, including an array of interventions that might make a difference in reducing new infections in sex workers and their clients. And these were data looking forward in a modeling projection over 10 years. And what they found, which when they initially reported it to us, I made them do it all over again because it's a little bit counterintuitive, was that, for example, treatment had less of an impact on reducing new infections for sex workers than decriminalization. And it turned out that decriminalization of sex work was the single most important intervention. It would reduce between 33 to 46% of new infections going forward. And this was modeled with data from India, Kenya, and Canada and Ukraine. So that's really striking, and that is really where the data is. And since then, as you may know, Amnesty International, the human rights organization, embraced the idea of decriminalization. There was a big push and a big struggle around that. We just had Homeland Security raid rentboy.com, the largest online sex work forum for men in the United States. We did a blog on this in the Huffington Post, trying to just put forward this scientific data again to say decriminalization really is potentially a potent intervention. And most of it is mediated. You might be thinking, what's the relationship there? It's mostly mediated through the kind of constant police harassment that sex workers get and the harassment that sex workers get for carrying condoms. Right? We all would like them to use condoms, and we will all encourage condoms. In fact, in the District of Columbia, when we had the AIDS conference here in 2012, and NGOs and groups working with women selling sex and transgender selling sex were handing out condoms to sex workers, and the DC police were still using carrying condoms as evidence of solicitation and sex work, right? So that has to change. All right. So when we looked at the data, this is a systematic review and meta-analysis by our group on transgender women. It turns out that transgender women are the most disproportionately burdened of any key population. This is all the available data globally. It's only for 15 countries. So we're just at the beginning of really understanding what's happening for this population. But I don't know how many of you are familiar with the odds ratios that we epidemiologists love, but if you are familiar, you will know that an odds ratio of 48.8 is an incredibly rare thing in science. So that means they're not twice as likely or 5 times as likely. They're not 10 times as likely to have HIV. They're almost 50 times as likely as other adults of reproductive age. And you can see the confidence intervals around that if you're interested. 31 to 76, that is robust. That means that at an absolute minimum, they're 30 times more likely to be living with HIV. So a little bit of data on PrEP in women. These are data from the ADAPT study where women at risk were enrolled in Cape Town, South Africa. And this was trying to understand if people would do better with a daily dosing or intermittent, coitally dependent dosing of PrEP. And it turns out, at least for these data, that women did much better with daily oral dosing. So much more like oral contraceptives, where daily dosing tends to be kind of habit forming and helps people maintain the regimen. So what was the big news just on September 2nd? So we're just now into what we might call the PrEP implementation era, where people are starting to have data not from trials and not from studies, but from real-world prescriptions of PrEP. So these are from Kaiser Permanente, a HMO. Some people love it, some people hate it. No comment. It's just that they have a database of people who've been prescribed PrEP. And in this case, they just published on September 2nd this nice paper looking at about 650 people prescribed PrEP through the Kaiser plan, followed for the last 2.5 years. It was open to people who met the CDC risk criteria for PrEP, so that would include women, people who inject drugs, transgender folks, but in fact 99% were either gay or bisexual men. So this turned out to be largely an MSM population. It's San Francisco data, so it's a community with high exposure and high risk. And what was the outcome? What happened to these 650 people followed over 2.5 years? Anybody know? It says it on the slide. No new infections. None, as in zero, among a very sexually active group of gay and bisexual men in San Francisco. You're supposed to applaud now, right? Yay. So, that is an incredibly powerful outcome, right? And this is not a trial. These are not people who are being pre-screened and carefully evaluated. That's not who we're talking about. We're talking about people who have talked to a primary care provider, explained that they have risks for HIV infection, had that discussion, started on PrEP, and now we're looking at them going forward and seeing how they do. So when we think about the rates of infection in these communities and the terrible health disparities that we see, this is a tool that actually has the potential to make a difference. But of course, this is Housing Works. You all care about social and structural issues. We know that. You care about poverty. People who can afford Kaiser Permanente private health insurance are a kind of a special group, right? And so this outcome maybe is a little better than we're going to see in some others. So we're going to have some challenges in many countries dealing with PrEP, particularly, of course, where being gay, being a sex worker, being a drug user is criminalized, is stigmatized, where people are not accorded human dignity and human rights in healthcare settings. We're going to have to be able to figure out how do we provide this new intervention to people in safety and in dignity. That is going to be a tall order in many places, and we are going to have a robust public education effort to stimulate demand for PrEP, but also to deal with some of the misinformed opposition that's out there to PrEP, which has been really a problem, at least in this country, and very often one that is very not evidence-based. So I'll just give you a feel that I gave a keynote couple of months ago at South Africa's National AIDS meeting, and the day I arrived, there was an anti-PrEP campaign being launched in South Africa. Right? You can guess who was funding that and where it came from, but it was the U.S. and really, I think, something very shameful. And I just want to close by thanking all of you for all the incredible work you do. Housing Works is really an amazing organization. I want to thank Charles for the invitation again, and wishing you a wonderful rest of the day.